The lessons learned from our work in other countries, one is that we have to develop technologies that can be widely used by diverse communities, people with a wide range of experience with devices, a wide range of education, and also a wide range of health disparities and barriers to medication adherence.
From Offscript Media, I am Matthew Zachary, and this is Out of Patience. That quote was from Dr. Bob Bollinger, the Raj and Kamla Gupta Professor of Infectious Diseases at the Johns Hopkins University School of Medicine. Why is Bob on today's show? Well, it's another COVID explainer because the world is still burning, and does anyone really have any answers? Well, it turns out that actual experts have the credibility to proffer up actual wisdom, unlike unnamed individuals who may think that injecting bleach into your body is sound medical advice. I'm digressing. Bob has over 40 years of experience dealing with, HIV, AIDS, malaria, tuberculosis, just to name 3 really terrible things. He's also the co-founder of what I find to be a very interesting mobile health platform called emocha, which focuses on improving compliance and adherence for clinical trials around the world. Joining Bob is his co-founder, Sebastian Seiguer, who is the chief executive officer of emocha. Lots of questions, lots of answers, but most importantly, this was a great conversation with some insanely smart people trying to make the bad stuff in this world suck a lot less. Enjoy the show. Hemoglobulin? I can't even say that word. Anyway, so we're gonna break down how do you pronounce hemoglobulin.
We can work on that one. Work on that pronunciation.
I'm a work in progress, I'll tell you. Bob and Sebastian, I'm very excited to have you here on the pod because you're bringing to the conversation expertise in 3 specific areas that have intrigued me for many years as a cancer advocate and somebody running a nonprofit organization. The first being telehealth, telemedicine. The second being compliance and adherence to medications and what those outcomes look like based on the factors that go into compliance and adherence. And COVID and immunology and infectious disease. Fascinating conversations that are slightly more prescient these days than perhaps other days out there. Sexy words that make no sense to the average person. But I'd like to start with your backgrounds because you can't just be the head of infectious disease at Hopkins without doing a couple of really good, smart things for a long time. So, Bob, how'd you get into this?
Well, thanks. First of all, just to clarify, I'm not the head of infectious disease at Hopkins. I've been a professor at Hopkins in infectious diseases for 30 years.
I gave you promotion.
Yeah, I appreciate that. I started off my career in infectious diseases, interested in global health, although I still do clinical work at Hopkins as well. I've spent most of my career involved in collaborations with colleagues in India as well as in Africa, focused primarily on HIV, tuberculosis, and other infectious diseases. And had an opportunity to meet Sebastian back in 2013 or so, after working on this mobile health platform to support a project we were developing in Uganda for HIV patients. So that's how I got involved in my career initially, and then how I got involved with mobile health and with emocha.
So let's dig into that a little bit, because obviously things don't happen the same in every country, and there are many variables that play into how do you come into that culture and figure out the right ways to work with those individual communities. What have you found to be the most relevant discovery in going into other countries to look at infectious disease and telehealth or disease management?
Well, I think one of the things we discovered and sort of has guided us from the beginning is that the needs for health are primarily focused in those communities and populations that have the greatest disparities, whether they be economic or social or health disparities. And that's certainly true in our experience in other countries as well as here in the United States. And so when we worked on developing emocha initially, we were focused on a very rural community in southern, southwestern Uganda. which was a difficult place to work, but we were able to develop strategies and platforms and solutions leveraging mobile health technology that could help improve the care of patients there. And then we took those lessons learned back to the United States, back to Baltimore, and it's really helped to launch what emocha's been able to do, and what Sebastian and his team has been able to do here in the United States for people that are having difficulty with adherence to medications, as well as to people facing the COVID pandemic at the moment. Again, like most health issues, disproportionately affecting people that are facing disparities in health and economics.
So going to Sebastian on the emergence of emocha, was it difficult to apply, or are you still in the mix of figuring out how do you apply the learnings, the best practices, the outcomes measurements that worked in other countries, or worked in quotes in other countries, to this country's very unique, very different health system?
Well, yes. I mean, in other countries, public health is health, right? Because, you don't have as much of a separation like we do here between what's considered the public health uses versus the commercial uses. So in other countries, and perhaps in Uganda or in India, in a lot of cases, the infectious diseases are of primary concern, whereas in the United States, they're not considered as high a priority sometimes, right? So this varies, and it depends on whether you have a situation like COVID. So really, there are very different systems.
So what have you applied in the U.S. that is unique? Because reaching different groups, communities of color, disparate groups, people that are already immunocompromised, what does it look like on the ground now with frontline responders and HCPs and nurses and doctors' health systems? How are they applying to everyday, I would almost say like triage?
Right. So, there are a lot of different uses for emocha. We can start with a couple major product qualities that we have that are really relevant today. So first things first, because this technology was developed abroad in a very rural setting, emocha works almost anywhere. We can capture data almost anywhere, and we've tailored the user interface for people who might have difficulties with technology, might speak a different language, and their usage is supposed to be rapid and easy. So in the same way, with the pandemic moving very quickly, we've distributed the technology to tens of thousands of people who have no problem using it, regardless of their background, because it is very simple and easy to use. It's meant to be distributed quickly and easily, and meant to operate anywhere. So that's one use. But note that there are two major, let's say, product tracks for emocha. One is when you already know that somebody has an issue, a disease, making sure they take their medication. That's our video directly observed therapy platform. And since the Ebola days in 2015, we have a software which is tailored to people who might have disease, who you have to monitor their symptoms to make sure that they don't have a very infectious disease. So we've deployed the COVID for COVID. We've deployed that. You could call it like almost a surveillance application.
So in terms of the actual tech itself, is it an app? Is it a web app? Is it a proprietary link somewhere? And my second question is, most of these countries now, can you comment, outside the U.S., do they have an internet infrastructure that they just didn't have even 10 years ago for this to work?
So emocha is a mobile application. It's a downloadable app. For medication adherence, we take a video of the patient taking their medication at every single dose. That's called directly observed therapy. We've proven comparability to the actual in-person process. Now, do developing economies have the infrastructure needed? Well, smartphone penetration in developing countries is actually very high, and more people will have a smartphone than they will a laptop, let's say. So yes, they rely on cellular networks to facilitate communication. There will be areas of the country which are rural and not as well connected, but in a lot of ways many of these economies in terms of smartphone usage are quite well developed. Bob, do you have comments on that?
No, I would only add, like I said before, the original version of emocha was developed in a very challenging environment, and we designed it to be flexible and be able to work in places that had all sorts of variability and connectivity. So that was really one of the intents.
Yeah, I look at the elasticity. How can this be applicable across multiple user experiences and multiple disease states and multiple cultures? It sounds like you did take that into consideration, but in terms of real-world application, what are you finding that users are looking for? What are you hearing from users that can be fed into the data to apply an outcome or an influence or decision?
So it really depends on the use case that you're talking about here. So let's talk about medication adherence. In medication adherence, we care that the patient takes their medication, obviously, keeping it simple. And we want to verify that at every single dose. But on the other hand, there are, as you yourself are expert in compliance and adherence, there are many reasons why a patient might not take their medication. And what we want to discover is why. The most tricky of those issues are medication problems. So sometimes patients don't take their medication because the dose isn't correct for them, or they don't know how to use a particular, let's say a device, for example, an asthma inhaler. So what we can learn by very, very frequent contact with a patient is the root causes of their non-adherence and how to solve it so that they can be successful with medication. With COVID, I'll let Dr. Bollinger tell you about the smoke alarm and how you use a smoke alarm versus how you use a smoke detector.
Well, so for the COVID use case, one of the things that's it's been used for is to help health workers who might have been exposed to self-monitor for symptoms of COVID on a daily basis and in a very convenient way. And as Sebastian said, the analogy I use is a smoke detector. So if someone who's potentially exposed to COVID has a symptom, you want to be able to detect that symptom as quickly as possible, so that data can then lead to actions that matter. So a good example is, if a healthcare worker develops a symptom, one of the most important things is to get that health worker access, if it's appropriate, to testing. So by providing health workers and others an opportunity to self-report and monitor their symptoms, it helps to facilitate their access to appropriate care, and it also helps to facilitate access to support from perhaps the public health department if contact tracing is necessary, for example. So it's all about collecting data that leads to good action, right? It's not just about collecting the data, but you want those data to lead to action that can help support the person that's doing the monitoring. That's really the critical component of it.
So I want to go back to the compliance issue, because that was really, I won't say a bone of my contention, because you really have to deal with multiple generations and the way they are purchased. And we were U.S. focused, and we focused on largely Gen Xers and millennials and even emerging Gen Zers. And we found that in leukemia, compliance was lowest in teenagers. And that seemed to make a lot of sense, because teenagers just kind of want to be teenagers. But there was almost a gamification product called Remission. It was like a CD-ROM. Remember CD-ROMs? It was a CD-ROM, then it was a DVD, then it was like a flash player. I'm really dating myself with this tech. But it wound up increasing compliance in teenagers' adherence to their medications when they were home on oral therapy, because it gamified the game like Doom. I'm so old. Doom from the PCs in the 1990s. You were like on a fantastic voyage spaceship going through your blood vessels, killing cancer cells. And that increased compliance among teenagers with leukemia. So have you seen evidence that there are disparate ways to reach different communities that need maybe bespoke tweets to encourage them to improve compliance and adherence?
So this is Sebastian. If you tried to gamify adherence for a teenager, you'd find that your game is old within a few weeks, and you'd have to make a new game. Their attention span is limited. But let's talk about with a teenager adhering to making your bed or cleaning their room or whatever other small tasks you want them to do. You have to be all over it. You have to remind them every single day. And if you gave them a checklist to work with on an app, they may or may not do it. We believe that medication adherence is both a technology, has a technology solution, but it has a human component as well. And that's how directly observed therapy works. A human being has a medication appointment with the patient nearly every single day to make sure it's being taken. So that's the behavior reinforcement, but then to remove any barriers that the patient might be experiencing. And these barriers can be significant when it comes to underserved communities. So I would say that gamification is great, but the barriers, like the attention span issues that you have, we have a very demanding consumer in terms of games that, you might not be able to keep up with in the healthcare setting. But there is a solution for teenagers. They just need more contact at certain times in order to get them to do what they're supposed to do.
Spoken like someone who may have a teenager in the house.
I've got 3 of them.
I called it. Totally called it.
Yep. Yeah, I think the male brain at that age, as Bob has, informed me many times, is just probably, at the dinosaur stage of development until the 20s.
So you're looking at daily interventions, human daily interventions to ensure that medications are taken, and here's why. Is there like an incentive base to this? I mean, we can get out of the teenage conversation in general. I'm going to tie that into another narrative that I'm an armchair expert in, which is that in this country, people sometimes can't afford their drugs, so they cut them in half to last the rest of the month till their check comes.
Yeah, there's as you may know, the measure of adherence in the market is the medication possession ratio, which is how much medication do you have, and does the number of refills cover you for a certain amount of time? And to your point, people cutting medication in half. Well, sometimes when they do that, they also get prescribed a double dosage of medication so that by taking half, they're actually taking what they're supposed to do. So therein lies the extreme value of a daily intervention to discover these things. Because imagine that you have somebody's prescription and it's, let's say, 2 doses of let's just say, keeping it simple, 2 pills of metformin twice daily. But that prescription in the system is actually a doubled prescription to allow the patient to only pay 1 copay and not have to refill at the end of the month. Well, on the typical measure of adherence, that patient will be 50% adherent. But on emocha, if we know that that's really not what they're supposed to be taking, and they're supposed to be taking 1 in the morning, 1 in the evening, then the patient's health will be secure and they will be actually adherent. So it's really tricky, and there are a lot of curveballs here.
So I'm going to channel Frank Sinatra for a second, because if you can make it here, you can make it anywhere. Has starting in international waters helped pave the way that this is a little more proof positive in the U.S.?
The lessons learned from our work in other countries, one is that we have to develop technologies that can be widely used by diverse communities, people with a wide range of experience with devices, a wide range of education, and also a wide range of health disparities and barriers to medication adherence. I think the other thing we've learned is that I think patients all over the world appreciate the opportunity to take better care of themselves in their own communities. So this is really trying to leverage, if you will, a new emphasis on point of care in the community, so in your own homes. And so it's a way to stay connected to the healthcare system in some new ways, from your home and from your community, from work. Because as we all know, one of the other barriers that people have to staying engaged in good health care is getting access to that care and taking time off from work, coming to the clinics, et cetera, which are necessary at times. But a lot of, we're certainly seeing some transformational things happening in healthcare around the world now due to COVID. Remote monitoring, remote care is going to be even more important. And I think in very rural communities in Uganda, that's a lot easier on people who live in remote villages and have to travel, for example, a long way to get facility-based care. So those are some lessons learned, I think, that we can build on and optimize how we use this technology that's, as Sebastian said, it's not just technology. It's people who are enabled by technology to help support patients who need help taking their medications.
Back with our guest after the break.
Has your chronic illness made it difficult to continue working in the traditional way? Want to learn how to find and create flexible remote work that both accommodates your chronic illness and generates an income? Join the Patients Getting Paid membership, a community of chronicpreneurs where people just like you find workshops and trainings, weekly updated condition-specific gigs, twice monthly coaching calls, co-workings, accountability, and the kindest community to support you on your path to make money while working from anywhere and taking good care of yourself. Learn more or join us at patientsgettingpaid.com.
Right, and that brings up the conversation of advocacy. So I was on the Google Health board 16 years ago when they were just getting started to think that this was something out there, long time ago. And we were discussing how advocacy could play a role, because if you're a patient who's made aware of a product that improves your life, you want to become an ambassador to that patient and let other people know that here's a product that helped you, and it could make, colloquially, things suck a little less. In the U.S., have you seen adoption rates similar to your success overseas, and what have the sort of user feedback been for you?
Well, I'll defer to Sebastian about providing some insights about user feedback from the United States. But I think in general, people appreciate the opportunity to feel better connected to their healthcare providers, and the technology can support that. I think to the extent that's achieved, people appreciate the convenience of it, as well as the opportunity to stay connected on a daily basis. Sebastian, you want to add to that?
Yes, I would say that, first of all, our user base is right now primarily the United States. I mean, actually overwhelmingly United States users. The best quote I have is actually from a healthcare provider in Harris County, Texas. We're still communicating. We're still having our daily appointment. We're just doing it on a different platform. And I'd say that what we've created is this highly novel and unique way for two people to have a conversation continuously, but to do that when it's convenient for each of them. And convenience means time, and it also means location. So we don't have to connect at the exact same time. We can do that at different times, but we'll still do it in a way that's personal enough that we feel that we've exchanged meaningful information. So that's where the asynchronous video comes in as well. So I think that we've just created a mechanism for communication between two people, which exchanges really, really, really important information about the patient's health and allows the provider to address it in a calm, measured manner at their convenience.
Yeah, I just love the idea of a normalized doctor-patient relationship through telemedicine. And it is really something that, again, with my weird crow's nest perch, has not quite formally penetrated the U.S. market psyche. And I conflate that with how no one really wanted to use PayPal for 20 years because they didn't trust it. But do you feel that pandemic has forced upon us a need to adopt and accept this? And I guess to that, will we see an uptick in, I'll almost say, a cultural acceptance that this is just a better way to live your life with a higher quality?
Well, this is Bob again. I'll let Sebastian add to this, but I think as we're certainly seeing that COVID is as we've mentioned, transforming, I think, for the long term, our emphasis on remote monitoring. But I think even before this, and certainly even now, a key issue is going to be the security and confidence that both patients and providers have, that this confidential health information that's exchanged in a very efficient way on platforms like emocha remains confidential, right? And and that's a really, really important thing, and certainly something, since we started this with a remote HIV care program in rural Uganda, security and confidentiality has always been really, really important and continues to be. And I think that'll continue to be something that needs to be addressed to assure people that using systems like this are safe and secure for them, and improve their confidence and ability to use them.
Yeah, hopefully it only took X years to believe you could buy something online with your credit card and not get ripped off. Hopefully this will happen a little more expediently in our culture.
Yeah, I think that the fact of the matter is that what we will learn here is that people, once they try something, get used to certain ways of communicating in the same way that we might fluidly switch between a text message and a phone call and a video call, or other means. We're used to that as consumers, and the healthcare consumer has not yet figured out that that's convenient, and the healthcare provider has not yet made it entirely convenient. And those things will change by force, because they have to right now, because patients really still need care as urgently as they did before, and will need to access it even if they can't come in.
I think that's fair. Rounding out the conversation, I did want to focus on COVID, and both of you, feel free to tell me you're not an epidemiologist or a virologist, but I have a couple of questions, because I was asymptomatically positive for antibodies. I got retested. My uncle is like a world-renowned geneticist, and he's been protecting me my whole life. And basic question is, how long, and this might be a skewed question, how long does it take to prove immunity after antibodies?
Sebastian, unless you want to be a virologist for the day, I'm happy to take this one. Well, look, this is a complicated and important question that a lot of people are asking these days, of course. The first thing to remember is that antibody is not, when we measure antibody with a blood test like this, we're not necessarily measuring just one antibody. We're often, depending on the test, could be measuring a whole cocktail, if you will, of antibodies that people make against this virus and other viruses. So to interpret the results of a test like this, you really have to understand the specifics of what test was used and what it's actually measuring, which type of antibody it's actually measuring. And so that can have a big impact on, for example, how long a test might stay positive. A particular antibody test may stay positive. And of course, since we've only been dealing with this epidemic in the United States for about 4 months, we don't have data beyond that to know how long it persists. But we're certainly seeing people develop antibody responses using a variety of different tests, usually within the first week to 2 weeks, certainly after 2 to 3 weeks of symptoms, in a large majority, most people, using most of the tests that are being used. But we don't yet know whether that antibody presence means immunity. While that doesn't necessarily protect you from a second infection or reduce the risk of that second infection, if you do get it, could be less severe, which is another thing that might actually happen. We know from other, this is not the first coronavirus that's infected humans. This is the 7th or 8th. We've had 4 others for many hundreds of years that cause a common cold. And we know that you can get reinfected with those on average every couple of years. And so with other coronaviruses, there's not a lifelong immunity for most people. So we yet don't know whether that's going to be true for this one as well. I'm actually thinking we're going to learn a lot about this in the next few months when we see how these new studies are going to result that are looking at convalescent plasma, where you basically are taking antibodies from people like yourself who have recovered, and you're giving it to people who either are at risk, may have been exposed, or sick with the disease, and you see what happens. And let's suppose that giving people those antibodies actually has a positive effect. Let's suppose we find out that it prevents infection in health workers or household contacts who might receive it. Well, that would be really helpful, because then it tells us that having antibodies does some good and may be protective. And that would really reassure us that the tests that we're using now to measure antibodies have some real practical value as far as immunity is concerned moving forward. How long it's going to last, I think we just have to wait and see. I'm not sure if that's answered your question or not, but let's see, maybe the virologist, Sebastian, wants to add more to that. I'm not sure.
Dr. Sebastian, please.
Well, look, I like to stay in my lane, and I've been counseled by Dr. Bollinger and several other experts that it doesn't really matter from our point of view whether somebody has tested positive or tested negative, or their antibody measurements are a certain value. We care about symptoms and whether somebody is experiencing those symptoms and how long they've been experiencing symptoms, because so much else is unknown. And so for the moment, those facts are very, very important in terms of whether that person isolates or is able to return to work, return to school, and be in the presence of others who they may be a danger to. Did I get that one right, Bob?
Yeah, I think you did. Just to put a final point on that, I think the test that matters in those scenarios is the PCR, the nucleic acid test that we've heard a lot about, and that because the antibody test doesn't tell us whether or not someone is infectious to others or actually is sick with that disease necessarily. And so we rely primarily on the other type of test for that purposes. And also to help us decide whether someone might be infectious to others and whether it's safe for them to return to work, for example. That's not something we can, at this point, confidently say based on an antibody test.
Right. I was PCR negative and IgG positive twice with the same test because I wanted to rule out, because my wife and kids were negative, and that just seems largely improbable. And I'm working on that Scooby-Doo mystery, talking to as many experts such as yourselves as possible.
Well, it probably depends on what type of test that you had. I mean, there are some tests that are positive and what we call false positives, and that means that the antibody that they measure are antibodies that could be from this particular coronavirus or perhaps also cross-react with other coronaviruses that we might have had an infection from earlier in our lives. But we're learning more and more. These tests are getting evaluated very carefully now. And so, and certainly it could be very well possible that you were exposed and had a relatively asymptomatic infection, and thank goodness. And now we're mounting an immune response. I think if you were infected, I'm glad that it was a very mild or asymptomatic case.
Well, surely a conversation that has no endpoint in sight. I want to congratulate you both on adopting a new precedent in recognizing the doctor-patient relationship as it comes to the human side of compliance and adherence. I want to wish you all the best with emocha, and you're onto something really important that I think is really going to make a difference in this country and clearly around the world. Bob Bollinger is the director of the Center for Clinical Global Health Education at Johns Hopkins Medicine, and Sebastian Seiguer is the co-founder and CEO of emocha. Gentlemen, thanks for joining us on this show.
Most welcome.
Thank you for having us.
The Johns Hopkins University has a financial interest in emocha, a technology that was invented at the Johns Hopkins University. This financial interest includes equity in the company and entitlement to royalties. Dr. Bollinger is an inventor of the technology, and he has equity and a royalty interest in emocha. He is a member of the emocha board of directors and is a consultant to the company. These conflicts of interest are being managed by the university in accordance with its conflict of interest policies. That's all for today, folks. If you like the show, be sure to subscribe, leave a review, follow us on social, and tell all your friends to listen. Out of Patience with Matthew Zachary is a product of Offscript Media. Our executive producer is Matthew Zachary. Our senior producers are Jen Horangeff and Andrew McDowell. Darren Tunn is our production intern. It is recorded, mixed, and edited by Matthew Zachary. Our theme music is by the Mike Van Allen Quintet and by Mara. For advertising and media inquiries, email media@offscript.com. Hit us up at contact@offscript.com to share comments, feedback, and make guest recommendations. For more information, visit offscript.com.